Good morning, everybody. We'll go ahead and get started. From what I can tell, there's 26 some odd people to me. It'll be starting in about 5 minutes. The meeting is also being recorded, so we can post it on the TRHA website for those of other people who may not have been able to see the entire presentation, or if some of you have to leave a little early because of other commitments, you can come back and pick up on the speakers that you missed. Our partner will mute everybody's mic and will only show the people or persons who are actually presenting, just to keep down the confusion. If you have questions, please use the chat feature. There'll be somebody monitoring the chat so that they can ask the questions to the different presenters. My name is Tommy Sweat. I'm the treasurer for TRHA. I'm happy y'all are here. We have some very good speakers today. And since we have 26 of y'all in the room eagerly awaiting our first speaker, I will go ahead and get that started. Our first speaker is Thomas Kowalski. He's the president and CEO of Texas Healthcare and Bioscience Institute. He lives in Austin, Texas. He has previously served as a senior staff member to Governor Bill Clements, Governor of Texas, the U.S. Senator John Tower, and Congressman Jim Collins of the Dallas area. He has 35 years of political and policy experience. He was appointed, it's been a long day already, in 1989 by Governor Bill Clements to the Board of Regents of Texas State University System. He served as chairman of the Board of Regents in 1995. In addition, he currently serves as chairman of the McCoy College of Business Administration Advisory Council at Texas State University. He is an avid public speaker. He gives numerous talks on positioning Texas as a global leader in the development of biotechnology and life sciences. He was appointed in 2002 to Governor Rick Perry's State Council on Science and Biotechnology Development. He is a former chairman of BioCouncil of State Biotechnology Association, whose national membership consists of 49 state associations involved in biotechnology development and advocacy. He is a distinguished alumni of Texas State University, a lifelong Texan, and he resides in Austin, as I said before, with his wife, Susie. Mr. Kowalski, it's all yours. Take it away.
Thank you, Tommy.
No problem.
And just a hello to Annette Smith, known as Ann. We went to high school together, and she chatted with me before, and it's good to see you. Well, good afternoon, everybody. And I have a PowerPoint this morning, and I would like to get it set up. There we go. So good morning. And the organization I represent, its acronym is THBI. It's known as the Texas Healthcare and Bioscience Institute. We were created in Austin in 1996, so we have been in operation for the last almost 25 years now. I was the founding executive for the organization, and the goal at the time was to really begin to create an initiative that would be able to recruit and build a very vibrant life science industry here in the state of Texas. In 1996, we had 500 companies. We had a very active footprint of academic health science centers, and we were developing a lot of products from medical devices to biopharmaceutical products, but they were leaving the state. The young companies were leaving the state. Our grads were leaving the state. And so there was a group of academic institutions and companies to come together to figure out how could we begin to build our own industry cluster, our own footprint here in the state. So I was asked this morning to speak to you about that and to talk to you about what is in our industry. How do we go forward? How do we go forward as a state? Where does West Texas play? What role? There have been a lot of positive developments over the last 25 years. But before I begin, I would just like to share with you the impact that medicines have on us. And right now, medicines are literally transforming our lives. Technology and innovation is transforming our lives. It results in longer and healthier lives. It decreases expensive hospital visits and emergency room visits. Medicines have helped raise the average U.S. life expectancy from 47 years in 1900 to 78 years. Since its peak in 1991, the cancer death rate in the U.S. has fallen nearly 22%. And today, a range of treatment options are available to hepatitis C patients, offering cure rates upwards to 90% with few side effects and as few as 8 weeks. And since the introduction of highly active antiretroviral treatments in 1995, the HIV/AIDS death rate has dropped nearly 85%. So medicines have had a tremendous impact. I wanted to share this particular graph because it shows a lot of first over the last decade. In 2008, first drug for symptoms of Huntington's disease. In 2009, you can see the first treatment for peripheral T-cell lymphoma, first new drug for gout in over 40 years. In 2012, the first drug to target root cause of cystic fibrosis. And over the last 10 years, there's been significant treatment. And in the last, if you look at 2018 and 2017, 16 new drugs to treat cancer. And of course, Texas, through the passage of the CPRIT program, of which Texas Tech has been a beneficiary of that. We'll talk to that momentarily. But 16 new drugs to treat cancer. And when we look at the cancer rates, they have dropped significantly. And as you know, no one of us or our families are immune from cancer. And we're continuing to make progress on this horrible disease. So let's take a look at the state of Texas in terms of where we are. And we've come a long way since 1996. But you can see today that we're home to more than 6,200 life science businesses and over 100,000 employees. Academic R&D expenditures of nearly $3.5 billion, and this is very important because in your hospitals and in our academic institutions, there is a lot of money flowing in from different sources, whether it's philanthropic, whether it's coming from the National Institute of Health, or any of the federal components. We're doing quite a bit of research, and that research will often turn into young companies. And so how do we continue to cultivate an environment where these companies will stay here and these companies will thrive? And I think we're turning that corner. We're showing some very robust statistics that point to our academic expenditures. In fact, before the talk, I was doing a little bit of research, and Texas Tech fares very well with all of our academic health science centers and our universities in the research field. They're in the top 10 for academic expenditures. And of course, the universities and academic health science centers in front of them are institutions like an MD Anderson, a Texas A&M, UT Austin, a Baylor College of Medicine, and a UT Health Science Center at Houston. And then there's Texas Tech. So they fare very, very well in terms of the expenditures and the ability to attract not only the dollars to do research, but to create new and innovative products. We have nearly $1.4 billion in NIH funding for the state. We have close to 5,000 patent awards to Texas inventors. Patents are the critical part, because with a patent, then a young company coming out of an academic institution has the ability to go raise additional funding to begin to prepare to take their particular drug or their medical device through the clinical trial process. Venture capital, we continue to do extremely well in raising money. As you all know, Texas is a very wealthy state. And so we have, from angel investors to the institutional investors, we are ranking in the top 10. I wanted to show you this particular graph because this is the one that I use when we talk about the state of Texas. For those that aren't familiar with the state of Texas, we also we like to work very closely with our members of the legislature and their staff to be able to help them understand where this industry is headed. And you can see that we're employing over 100,000 people. When you look at the quintiles on the far right, you're going to see that this is produced by an organization called Bioinnovation. It's the largest trade association for the biotech industry in the world. And so every other year, they will produce a report every other year. And so for the last 4 years, we have, as a state, have landed literally of the 10 quintiles that they recognize, we've been in the top 6, and the numbers continue to grow. And you can see where we are, particularly on the top quintiles, from bioscience industry employment to, once again, bioscience R&D, looking at the amount of funding from NIH, which is very critical to our research, also to bioscience venture capital investments, and then the bioscience related patents. These are all engines of growth in terms of our life science industry here in the state. Texas is extremely competitive. Every state right now is extremely competitive in terms of growing its own life science industry. COVID has really brought attention to the fact of what it takes to bring a drug to the marketplace, the timeline it takes. And I know that every morning we wake up, we're glued to the press in terms of where are we in terms of the status of drug development to find a vaccine or a treatment. We'll talk about COVID momentarily, but these are some of the competitive programs that THBI has helped and supported really to get passed. We have the Texas Enterprise Fund, which I know many of you are familiar with. It's the governor's fund to attract businesses and new jobs to Texas. The Enterprise Fund has a jobs quota to it, and so when a company receives funding like this, they have the ability to produce a number of jobs to receive that funding. And the life science industry has been a strong beneficiary of the Enterprise Fund. There's the Governor's University Research Initiative. Its acronym is GERI. This is a fund that the governor uses, and it's funded by the legislature to be able to recruit top talent to the state of Texas. And so literally for over the last 10 years, we have actively, through this fund, been recruiting top researchers to the state. When a researcher comes into the state, it will bring its team, it will bring its portfolio of research projects, often many of those which would then be commercialized. So this has been in place, and it has really helped us begin to, looking at the length of time it takes to bring a biopharmaceutical drug or a medical device to the marketplace, bringing a researcher in place and beginning that process. It takes many, many years before an FDA will give its approval if it goes through successfully a clinical trial process. There's a product development and small business incubator loan program, and this acts as a regular bank. It's very friendly to small businesses. In fact, its goal is to attract small businesses to come into and offer its loan. It gives favorable rates, but it acts just like a bank. You have to pledge assets, you have to pay the loan back, but in times like these, it could be a very favorable place for a small business, which is normally a young biotech company, to go to and to be able to process those loans. I think one of the big transformational initiatives that we've had in the state of Texas has been the Cancer Prevention and Research Institute of Texas. Its acronym is known as CPRIT, and it awards grants to, it does several things. It matches grants, it recruits talent, just like Geary does. It invests in companies, and this has been a very successful program for the state of Texas to actually take equity in a life science company, and it's very oncology related. And then it has a preventive component to it, which has literally touched every county in the state of Texas, which are responsible for mammograms, all of our testing in terms of cancer-related proactiveness. And so CPRIT for us has been, I think, a game changer for the state of Texas. It was originally set up as a $3 billion program over a 10-year period. This last legislative session, we were very supportive. It was one of our top priorities as an organization to get CPRIT back on the ballot for another 10 years and another $3 billion. So now we literally have a program that is oncology based that is now a literally $6 billion program over a 20-year period. And this has brought a lot of attention to the state. In fact, this is one of the largest grant organizing or grant application outside of the NIH. So this has been a huge boon for the state of Texas. Let me pause here just to mention that as an organization, we often will every year we take large delegations to the Bio International Convention. It's the largest gathering of biotech executives globally. We do a pavilion. We showcase Texas. We take representatives of the governor's office with us, the Department of Agriculture. We take representatives for CPRIT. And over the years, as word has gotten out globally about the CPRIT program, our booth in the pavilion has always been probably one of the more visited booths simply because of the program that exists and the opportunity to do business here in the state of Texas. And I will just mention that over the years, we have probably been doing this for the last 12 to 14 years. We've had representatives from Lubbock, Odessa, Abilene. In fact, Abilene went with us in 2017. Amarillo was headed this year, but because of COVID, the event went totally virtual, but we're looking forward to 2021, and hopefully in Boston in June, we will be gathering and we will be taking another delegation with us to that particular event. Let's talk a little bit about the R&D tax incentive. This is a credit that works for both small and large companies. And the state of Texas, literally, it is what it says. It's a research and development tax incentive credit, and where you could take actually credit on sales tax that you would buy for equipment that would be used for R&D purposes. So these are the programs that the state of Texas utilizes to be able to help recruit companies into the state of Texas. And with the focus on the life science industry as an emerging industry cluster, which is now grown into a full-time, we think a full-fledged cluster for the state of Texas, it's very important moving forward, particularly with COVID. I think COVID has, as you all know, has changed the landscape in terms of what a post-COVID environment is going to look like. What is our workforce going to look like? We'll talk about COVID momentarily, but currently these are the top national rankings for the number of workers in key biotech-related occupations, from chemical engineers to veterinarian technologies and technicians. And by the way, congratulations once again to Texas Tech for the veterinarian school. And I just read where the goal, and they're right on track to fill their first class in 2021. This is a very important step in terms of the footprint itself due to the clinical trial process and the animal testing that will occur. So hats off. But as we talk about the number of workers and the workforce development in the state, both from the amount of university presence in the area through Tech, through West Texas A&M, through the very robust community college footprint that exists, Today, training is going to be key. In fact, the top occupations in the High Plains areas, out of the top 5 occupations, health diagnostics and treating practitioners and health technologists and technicians are 2 of the top. And so today, as we're moving forward in a post-COVID environment, the training is going to be very critical. In fact, workforce is going to be one of the key areas moving forward. And it can be community college certification. It could move up to a Ph.D. level, can move up to a C-level suite in terms of a CEO all the way down. We're going to need a very robust platform in terms of not only talent recruitment, but also in talent training. I think the key question that we ask ourselves, and it's already beginning to happen in some of the other areas around the state, but we're able to recruit large organizations into the state, and we're able to fill workforce needs. So as we move forward, workforce is going to be very critical. So let's look at some of the ingredients for building a critical mass in the biosciences in the state. And I know that you all know your region. I know that you know the state of Texas. When we look at it from a life science perspective, we can look at, once again, engaged universities with active leadership, because it's not only going to take the health science centers, it's going to take our research institutions, all of which is being accomplished from literally Sul Ross, Angelo State, West Texas, A&M, all the way through Texas Tech, and leading all the way to El Paso with the footprint. In your area, obviously you all are drawing to your own institutions, but through Texas Tech, you have the Graduate School of Biomedical Medicine, you have the School of Pharmacy, you have the School of Health Professions, the School of Medicine, and the School of Nursing. And as we all know, we are already in a nursing shortage, and how do we continue to produce the quality of talent that we're going to need to continue to do this. Building entrepreneurial cultures with intensive networking across sectors and with the industry. I think that our universities and as we move around the state of Texas, I mean, obviously we can take a look at the medical center in Houston. We can look at Dell Medical School in Austin. We could look at the healthcare initiatives in San Antonio. We can look at the convergence, at least here in Austin, of technology and healthcare, the wearables, where we're headed. And now with COVID, we're looking at telehealth as we begin to move forward, which I know is going to be discussed at the next legislative session. Available capital covering all stages of business cycle. It's going to be critical for the life science industry in terms of the ability to raise its money. This is primarily through the venture capital and ultimately through the markets. Discretionary federal or other R&D funding, we're already demonstrating our ability to recruit those federal dollars. We have the ability, and you could take Texas Tech, we have the ability to go raise the philanthropic dollars to come in. So when we have that mix, it makes for a very powerful mix in order to continue to build a very robust life science industry moving forward. Access to specialized facilities and equipment. You can go onto our campuses today, and of course, as we're moving forward into the next legislative session, it's going to be important that tuition revenue bonds will be looked at, because we are at capacity right now in our classrooms. We need to continue to invest in our academic institutions. And of course, once again, what will COVID do, and what will be the implications in terms of moving forward? We've talked about workforce and the talent pool, and then supportive business, tax, and regulatory policies. This is really very important, I think, in Texas. We don't have a state income tax. We're hearing more and more about that these days in terms of the attractiveness of moving here. We recently had Governor Abbott's the executive director for their economic development shop speak to us on a webinar, and her her comment was, and I'm not speaking for her, but her comment, as a paraphrase, was she's hearing more and more from CEOs outside of the state of Texas, and they're saying, how can we get there? We need to be there. Texas is a great place to do business. And so we covered those, from the R&D to our secret program to our enterprise fund. The life science industry has been a huge beneficiary of those. And then patients in a long-term perspective. I'd like to just share with you a couple of stats. What does it take to bring a drug to the marketplace? And I know I'm speaking to an audience that understands this business, but currently it takes $2.6 billion. It's the average cost to develop and secure approval of a new medicine, taking into account all the trial and error and the research failures along the way and the cost of capital. This figure continues to increase, and the length of time it takes. 89 prescriptions in the US are for lower cost generic copies of once branded pharmaceuticals. That means that 11% are new innovative drugs. So how do we continue on the new innovative drugs? And we looked at the chart earlier in terms of the first ofs over the last decade. And I would assume that over the next decade to the next 20 years, the landscape and the innovation is going to continue to evolve to better serve our patients. 70% of innovative clinical programs are being led by small companies, which rely heavily on venture capitalists, angel investors, or partnerships with large pharmaceutical companies to provide enormous amounts of private capital required to fund these challenging times. 1 in 10,000 compounds being analyzed today will actually make it through the FDA process. So the failure rate in terms of bringing a drug to the marketplace is very high. 90% of clinical programs will ultimately fail in the FDA process. In fact, the success rate of clinical trials can be even less, particularly like Alzheimer's and cancer. 92% of biopharmaceutical companies are unprofitable at any given time. And of course, we had mentioned the length of time, it's 10 to 15 years. We're going to talk about the length of time in terms of COVID, but before we move into that, Texas right now has one of the highest rates of clinical trials that are occurring here in the state. We currently have over 28,000 clinical trials underway. And of course, here, let me just move this map to show you as we once again take a look at the footprint that we have in terms of the life science companies in Texas. This graph we obtained from the governor's office, and you can see that we have attracted a number of large companies that are here. I have a feeling that post-COVID, we're going to be able to add to this list. And I think there's an opportunity for the state of Texas to begin its recruitment process in terms of just the business climate that we have. And it's not just going to be in one location. As you can see, that the companies, and this is part of a footprint of 6,000 companies, continues to come to Texas. These are also medical schools and selected research centers. We are continuing to add medical schools to the landscape. Our academic health science centers have really become some of the stellar places that are attracting top researchers. And once again, this is all a part of the recruitment of talent that we have to the state, the research teams that are coming in, and then the application of the research projects that are underway. And you have to take into mind that out of these research projects, there's a lot of commercialization going on, and this has helped fueling the growth of the life science industry. And once again, in 1996, when we opened our doors at THBI, we counted 500 companies. Today, we're at 6,200 companies. 2 years ago, we were at around the 5,700 marker. So you can see that we're continuing to grow, but it is because of programs like CPRIT that we're seeing this particular growth. This will give you a map of the clinical trials around the state of Texas. And the clinical trial activity has also continued to grow. COVID is attracting a number of clinical trials into the state. So we're adding to it. I think a goal of our organization would be that it would be nice to go to a clinical trial in your backyard instead of having to travel and dislocate a family have the cost of traveling to a distance with hotel and meals and just being out of your home. So as we continue to grow the clinical trial footprint, then I think it's going to better serve our patients in the long run. We lag California. Texas and New York flip every other year. We're currently second in terms of number of clinical trials, and so we're continuing to grow this. Let's talk a little bit about COVID, if we could. And I know that COVID is at the top of everybody's minds. We are currently, there's a tracker that we use that I would highly recommend for you. I know that you get a lot of your information from a lot of credible sources, but we use a tracker, and it's at bio.org. They update this daily. It's an interactive tracker where you can come into the website and you can literally click on any of the areas, and it will give you company. It will give you a number of stats that could help you in terms of tracking COVID and where we are currently. Obviously, the United States is the leader for COVID. There's one thing, and I know that we track this every day, but I just wanted to briefly just share this with you. On March 4th, DSHS reported Texas' first positive case to the coronavirus in Fort Bend County. March 4th seems like years ago. The patient had recently traveled abroad. A month later, on April 4th, there were 6,110 cases in 151 counties. And as of yesterday, there were 743,284 cases in 252 counties. So you can see that we're continuing to add cases here in the state of Texas, over 15,000 deaths. And of course, the timing now, we had talked about the time it takes to bring a drug to the marketplace, but literally over the since March the 11th, you can see that we have 737 active compounds in development, close to 200 vaccines, 198 antivirals, and 351 treatments. This last week, when is today? Thursday. On Monday, I had the opportunity to visit with the Surgeon General of the United States. There was a meeting held here in Austin, and there were about 8 of us that sat down with the Surgeon General. And I think my takeaway, and one of the things that he said, was that we're slowly headed to the downside of the virus. And I know that when we look at the time it takes to bring a vaccine to the marketplace, the industry itself has made phenomenal moves. But I think one of the important things that we are beginning to see as we're moving towards finding a treatment or a vaccine is the amount of collaboration that's occurring with not only the pharmaceutical companies, but the medical device institutions for PPE, and also for the collaborations with a number of the government agencies. We spent some time talking about that in terms of what does it look like moving forward. We have, as an organization, have held about 20 webinars to date. We've centered a lot of these webinars on COVID. I've had the privilege of moderating a number of meetings with our biopharmaceutical companies. A number of executives have come through, and I think what we're beginning to see is in a post-COVID environment, there's some themes that are emerging and some things for us to think about moving forward. And I'll just share some of these with you. Funding for medical research must be sustained and predictable. We can't let one event pass and then all of a sudden the priorities centered around this event begin to be in the rearview mirror as we move forward. So medical research must be sustained and predictable, both on a federal and state level. Public health infrastructure is essential, as we have found out. One of the things that the Surgeon General brought out is that the current system pre-COVID was broken, and it's really come to light in terms of what's occurring today and how do we strengthen that moving forward in a post-COVID environment. Workforce is critical, and we're going to need to continue to produce a very vibrant workforce, which to me, I think our community colleges are the crown jewels, and our academic health science centers and our medical schools producing our residents is going to be critical here in the state of Texas. Venture capital is critical, and the funding of venture capital. So how do we begin to explore ways to incentivize the ability to attract dollars not only to Texas, but to the companies that we are creating, because that pipeline continues to overflow in terms of the innovation that is an outflow of the research that we're creating. And then the ability to create and manufacture. And I think this is going to be a huge opportunity for the state of Texas. Every city in our state has an opportunity to recruit because of the business environment that we have. And so I think this is going to be a huge subject. I'll share with you, when COVID first hit, obviously the phone calls that we were getting were the shortage of PPE, but shelter in place was also very critical. And shelter in place was determining non-essential employees. When we look at a biopharmaceutical setting, those laboratories must be accessed. If we look on an academic setting, those labs with the cultures and the research that is occurring, they have to be accessed 24 hours a day. So we were getting a number of calls in terms of what a definition of shelter in place would look like. We worked with, and here in the state of Texas, mayors and of course with the governor's strike force, we were able to put in place shelter in place definition that would allow our workers and our researchers to access their labs. That's going to be very critical moving forward. One thing we have found out is that this is not going to be the last pandemic. And so what are the lessons that we're learning now, and what are the lessons that we can put in place as we do begin to move forward? So we are continuing, let me go to my last slide here. We're continuing to be in touch with those CEOs and those folks on the ground. I think there's a commitment moving forward as we look at a post-COVID area or arena. You know, obviously healthcare is going to continue to be the pillar of a future Texas economy. And we have to, looking at this next legislative session, how can we continue to be competitive with other states, because the competition is extremely competitive. You can speak to your economic development or your chamber representatives, and they will tell you it's extremely competitive, particularly in this industry cluster. I think we need to continue to educate our lawmakers, which this has been a tremendous learning curve, I think, not only for our elected officials on a federal, state, and a local level, but it has been a tremendous learning curve, I think, for all of us to understand what a pandemic can do, number one, what it can do to an economy, and but what does it take to find a cure and a treatment to be able to do this? So how do we prepare now for the future? How do we successfully incorporate ideas, good policy? In our opinion, bad policy will chill innovation. So how do we continue to put solid policy in place and having that patience to be able to bring those drugs to the marketplace? And then I think we have a class of CEOs and we have a class of committed individuals within the life science arena that are willing to help with the process and are willing to work with policymakers to be able to craft solid policy moving forward. So I know that I'm coming up to my time. I'd be happy to take any questions. I just want to say I reviewed some of the webinars that you all have produced, and I'm very honored. I listened to Congressman Arrington, Tom Banning, John Hopkins, Dr. Phillips. So thank you for allowing me to present to you today to give you some of our thoughts from our organization. I've enjoyed it. I'll answer any questions that you may have. Tommy, do I still have you all?
Oh, everybody's here. It may be that nobody has any questions. You did such a good job with your presentation.
All right. Well, thank you very much.
We appreciate having you.
I have a question, if I might.
Yes, ma'am.
This is Paula Winkler with the AHAC in San Antonio. There are a lot of high schools now that are looking towards getting kids into the workforce, and health workforce is a big area, but a lot of the resources that rural ISDs have to get their kids into things like nursing and to pharmacy techs and things like that are just not available. So is this something that we could approach some, you know, kind of grow your own kind of approach that we might look at, that we could then approach these larger companies to see if there might be an opportunity to help fund some activities like this?
You know, there are a number of companies that could offer grants, and it's going to take the opportunity to see what dollars are available. That's one option. I think there's another option to talk to the Texas Workforce Commission to see what may be available, particularly in a rural setting, to be able to help encourage and get our young students excited about the potential of a healthcare field. I think what COVID has done is it's cast the not only the need, but it's cast the opportunity in terms of what the needs are to be able to help fight not only this pandemic, but for future pandemics. And I think there could be discussions with members of our legislature. You all have a tremendous delegation representing, particularly in the West Texas and the High Plains area. You have a phenomenal delegation that understands the need for greater workforce dollars and training. And then another area might be this, and this is one, in fact, the Texas Workforce Commission is having a meeting today simultaneously with this meeting, having this very same discussion in terms of workforce training and the needs. I think it's important to listen to the companies and the institutions that you're operating with, and to figure out the needs and how to work with the community college infrastructure to be able to craft that curriculum in terms of recruiting and then training our future students. But the healthcare, and you're in San Antonio, that healthcare is the top occupation in San Antonio. So I think it's going to cross, and once again, as we move into a post-COVID environment, I think these are going to be the lessons learned. Were we prepared? Did we have the workforce to meet the needs? And then how do we prepare moving forward?
Thank you. That's good encouragement. I appreciate it.
This is, I have a question. This is Ninfa Pena-Purcell, professor. I wanted to find out, as I started hearing this work and what was chimed in with students in rural communities, I wanted you to speak to how your work, especially in these COVID times where the disparity gap is widening, and where your efforts are doing in focusing on addressing health disparities as we get vaccines tested that are using subjects for minority, all of this work is great that you've been speaking about, but what I really think about is how we address disparities in care and reaching access to care and services that are represented in the work that you do.
That is an excellent question. We are, as an industry, in fact, the national trade organizations like the Pharmaceutical Manufacturers of America or the Bio International or the Bio Innovative organizations, they are looking at diversity, equity, and inclusiveness across the whole spectrum. They have begun to examine what are going to be solid policies moving forward for an aggressive DEI campaign. And it would be recruitment on boards, the recruitment of employees, and then taking a specific look at clinical trials and coming up with specific policies in terms of the recruitment from the minority populations into clinical trials, and how to be able to achieve progress in that area. So I think there's a recognition, a very strong recognition. In fact, this last week we held a webinar on DEI with the new inclusive individual that they brought in at the Bio International. It was very widely attended. And so I think we're going to see some specific policies coming out. How do we work with our contract research organizations to be able to look at the recruitment processes, and how do we look at areas not only along the border but in rural Texas to recruit folks to come in to the clinical trial process.
Great. Thank you so much. And you and I go back. I graduated from United too.
Oh, who is this?
Ninfa Pena Purcell.
Oh, hello, Ninfa. How are you?
Doing good. Faculty professor at A&M. It's been good to talk to you.
It's a pleasure to see you.
Mhm.
Any other questions? Once again, thank you very much. THBI.com is our website. My email, tk@thbi.com. Please feel free as a follow-up. And once again, thank you very much for having me this morning.
Thank you.
Well, good afternoon, everybody. I'm Paul Fabrizio. I'm a professor of political science at McMurray University, and I am affiliated with the Texas Rural Health Association. And I thank you for joining us for this webinar that we're holding, not a seminar, a webinar. And this is the second part of it, the second speaker. So let me just introduce our speaker, Blair Childs, and he will be speaking on healthcare in an age of COVID disruption and Washington in the marketplace. He is the Senior Vice President of Public Affairs for Premier, leading the advocacy, communications, and safety and thought leadership units, and serving on the company's executive team. He works with the Congress, the White House, and other policymakers in health policy. He has been at the center of policy issues for more than 2 decades, playing a leading role on issues impacting medical devices, pharmaceuticals, insurers, and hospitals. He has held senior management positions in professional trade and advocacy associations, and also a Fortune 25 company. So, Mr. Childs, thank you so much for being here, and it's all yours.
Yeah, great. Thanks, Dr. Fabrizio. Sorry.
Yes, okay.
Good to be with everybody today. So I have a lot of content I'm going to try to cover. So, and this is complicated, and it's a complicated time, and there's a lot going on. So I hope the audience has got their brains turned on, and the synapses are clicking, because I'm going to move quickly. And what I think I'll try to do is pause at a couple of different parts of the presentation, see if there are any questions. So I think as I go through, and if you have questions, just be ready with them when I pause, and happy to try to address them. We just don't have a lot of time here, so I'm going to move at a pretty good clip. So again, hopefully you'll be able to follow this all. So first off, let me just make sure it's clear on where I'm coming from. I work for Premier. Some of you may be familiar with Premier. Some of you may be working with Premier. So we have a very large footprint in healthcare, work with over 4,100 hospitals in the country, 200,000 non-acute care sites. We actually have a very big footprint in rural healthcare organizations, a lot of critical access hospitals and others that are involved in Premier. We basically use data and data-driven efforts and the power of collaboration to drive performance improvement, and we do extraordinarily well in that. What we try to do in this is we have continually been focused at how do we understand what the challenges are for healthcare providers in terms of cost and quality, And we are always doing that using our data-driven systems. Then we actually design, test, and scale new models of care delivery. So some of you may be familiar with things like value-based care, ACOs, bundle payment. Premier and our members have led the way in testing those new models of care. So we actually ran the largest demonstration project that Medicare has ever run. We ran it and it led to the law which created value-based care. Same thing with ACOs and bundle payment. So we've been at the forefront of all these changes. And what I do is I take what we learn in these collaboratives and our team that is in Washington to policymakers, because I know everyone's going to be shocked to hear this, but most members of Congress and policymakers don't really understand healthcare very well. So these are our examples of our collaboratives, which are hospital performance improvement collaboratives. We have bundle payment collaboratives that we run, as well as ACO collaboratives. And the things that, if you have a chance to look at the data here, and then some of our even more recent data, we have consistently outperformed the rest of the country in these payment model reforms. And we also have a group purchasing organization, which is essentially a collaborative, which is a data-driven collaborative like all of them. And it's also differentiated in delivering, really higher performance than any other. And we have lots of evidence that points to this than any other such supply chain entity that's out there. So I just want to say, leading into the first part of my presentation, which will be on COVID and what's going on right now in Washington on that, we have been extraordinarily involved in this area of work. Premier actually organized a private sector coalition, which included all the group purchasing organizations, all of the distributors, as well as all the manufacturers. And we worked hand in glove with the administration, with HHS, FEMA. I can't tell you how many other departments and agencies in the government through this pandemic. This coalition probably was, and it's been cited numerous times by the president as well as the secretary of HHS and others, as being one of the most significantly effective efforts that have been undertaken around the pandemic to really help the country manage through this from a supply chain vantage point. Because when the pandemic hit in early March and everybody became much more aware of it, FEMA stood up and HHS stood up an effort to try to manage all of this, and they were struggling to even understand how healthcare works. And so this coalition became the one-stop shop for them to actually coordinate with the private sector, and it really was highly effective. So my only point is that we had an enormous impact from a policy vantage point, enormous impact from a supply chain management vantage point, and also we're continuing to work very closely with the administration and with folks in HHS and FEMA, et cetera, from a technology and analytics vantage point. So we've got a lot of expertise and knowledge and insights into all this. So here's what I'm going to go over. I'm going to quickly hit COVID-19 and kind of where we are on that, then talk about the election and some political and legal realities, and then talk about the biggest trends going on that I see in healthcare that people should be aware of. So in terms of COVID, I think everyone's very aware this has been just monumental in terms of its implications for the country and all. And just how significant it's consumed everybody. No shock there. It's been a huge response from the federal government, and we, there's been a lot pumped into the economy. Probably in total around $8 trillion when you look at all the money the Fed has spent. And then there's a lot of discussions right now about a 4.0 package. And it doesn't look positive as of today. I just was looking at some of the things that are out there in the discussions in Washington about, going on about negotiations between Mnuchin and Pelosi on trying to get a deal. And so we'll be looking at a lame duck session. There'll be something done there. in all likelihood, but does not look super positive right at the moment. Although I will tell you that, the way Washington works is everything looks bleak until it's not bleak anymore. So we'll see. And it's just remarkable to think that at the beginning part of the year, people were talking about Medicare for all, surprise medical billing, drug pricing reform, impeachment. I mean, these were all things that were, obsessing the country. And it seems like years and years ago, and they're really gone. And we'll see what happens in terms of the future. I think most folks are probably aware of the Provider Relief Fund, which has got about $175 billion allocated to it. 121 of that has been spent. Or I should say, has been announced. They've only actually distributed around, I guess at this point, it's around 80 billion of it, of the 121. So there's a lot that still hasn't been distributed. Most of the money has gone to or is going to hospitals. And actually, I should say it's more than 80 billion that's been distributed, but it's not the full 121. They just announced like an hour ago another distribution of $20 billion to other providers like behavioral health providers and others. So I'm trying to sort through exactly what that means. I haven't had a chance to digest it all, but this is out there, and hopefully your members and you all are aware of it and taking advantage of this, because it is an important way for providers to help get through this and manage through this pandemic. A lot of focus right now is on the vaccine and where things are. Obviously, lots of confusion about sort of where we are in the development process, but there are 8 companies with vaccines. There's 4 that are in advanced clinical trials at this point. I shouldn't say that 8 are in advanced clinical trials, but 4 are actually in the advanced clinical trials. 8 have got vaccines that are in development. The states are being told to prepare for distribution as of the 1st of November. And the goal is to distribute them within 24 hours of FDA approval. And then the providers who are, going to be distributing or administering the vaccines don't have to pay to carry the vaccines, nor will consumers have to pay out of pocket to get the vaccines. But this is obviously a big focus. There is a National Academies of Medicine series of recommendations about how these are to be distributed. They're actually being finalized tomorrow, but this is the current allocation. 15% going initially to frontline healthcare workers and other responders, along with the at-risk population, and then it goes to the next tranche, which is essential workers at substantially high risk, and then the other remaining older adults, and then then it really goes to the rest of the population overall. So this is how things are meant to proceed. It is going to be an extraordinarily challenging endeavor to get the vaccine out there, distributed in a sensible way, to track patients who've gotten it, because I think most people know that most of the vaccines are 2 doses. There is the J&J vaccine, which is 1 dose, but most of them are 2 doses. So you've got to make sure you get the right vaccine at the second, administration, if there's a 2-step process. So all of the tracking, the distribution, the storage, all these things are very, very important and complex, and they're all being done through the states, and the states are going to be responsible for the actual distribution in each state. In going back to sort of what's going on in DC at this moment, in addition to planning for the distribution of the vaccine, is, I mentioned this COVID relief package. We should know this week if something can come together on this, but it is looking tough. My guess is the biggest stumbling block could very well be liability reforms in the package, but who knows exactly, more to come. We are looking, they did pass and just got done the continuing resolution, which continues to fund the government through now December 11th. So they kicked the ball down the field, and we are headed toward then the election and a lame duck session. I would just say in the lame duck session, there will be, if they don't get something done before the election, there will be some kind of provider relief passed and other sort of support for the economy. It's unfortunate we can't get it done before the election, but this is classic politics, and it's everybody's trying to get their particular priorities done or not done if there's something that they want to stop, and that's what makes it really, really difficult before an election. I could go into a lot of detail, but after the election, there will be a lot of things done. So there will be another stimulus COVID relief package. There will be legislation strengthening the supply chain. These are the kinds of reforms that are likely to be included in that. There will be additional money and activity focused on updating our public health infrastructure and health information technology systems. So there's going to be a lot done in the lame duck session after the election. Just a couple of important realities of what's gone on here that you can't escape. That because of this incredible experience we are going through, have gone through, and are going through, the pressure on a federal budget, and when you look at how much has been spent and how much this is impacting our deficit and debt. And now the Medicare Trust Fund, which is sort of the symbol of how we are doing financially for Medicare, is going to be bankrupt in 2023 or 2024. So the next president's going to have to deal with this. This is going to be a huge political issue. And what exactly it means in terms of the healthcare system. I think the implications are, I've already said about the first one, but the second one is that there's going to be an increased focus at value-based care, and that means more accountability for healthcare providers. And I think on drug prices, those are the two areas I think there's going to be a lot of focus. I also think it could mean more mandatory new alternative payment models. I'll talk more about that in a minute. And I mentioned the drug pricing. So these are just things that when you think about what we are going through, some things that I think many of us have thought about, probably many of you have thought about in terms of the implications of this epochal event on us as a society. And I think it will mean actually deregulatory action, because we've learned a lot about how the regulations have impeded care delivery. So this is everything from the use of telehealth across state borders to staffing requirements and other kinds of requirements that exist in healthcare, which is so heavily regulated. I think we all know that we'll see more telehealth and remote monitoring and home care. I've already mentioned the budget pressures. I've mentioned value-based care, hospital infrastructure investments. I think you're going to see more focus on that, obviously. Whether we end up moving towards more focus on, it's clearly meant that those people who cared less for themselves were most likely to perish in this pandemic. And so the whole focus on health and prevention. So there's just a variety of things that are out there, including, reduced confidence in government. And obviously this is going to be the number one issue in politics going forward. So before I jump into the political realities, the election and so forth, does anybody have any questions? Let me just pause for a moment, or things that they want me to clarify. I don't know how we're doing this, whether people just take themselves off mute and speak or what, or you send things into a chat box, but any questions? Is anybody out there?
I think anybody who wants to speak can just unmute themselves, and They can go ahead and do that. And while they're doing that, let me just ask you a question. You said that what we've seen is that some of the regulations have really limited healthcare delivery. Could you be more specific about that? What kind of things are you talking about there?
there's things like there's a lot of staffing requirements, particularly for like a critical access hospital as well as other hospitals. There's also restrictions on using providers from other states and telehealth. So there's those kinds of restrictions. Those are regulations that exist, that you need to have certain kinds of staff members manage certain patients or certain situations in different settings of care. And there's been much more relaxation of those regulations during the pandemic. And I think many have found that those regulations were unnecessary, and that you don't need to micromanage providers quite as much as we've got in the current system. Does that make sense?
Yes, thank you very much.
Okay, well, if I don't have any other questions, just I'm going to keep going because we don't have a ton of time here. So this is a little bit of the way things are these days in Washington, and it's been pretty crazy, and we'll just have to see what happens in the election. But here's my breakdown of things, and just wanted to start with sort of an overview that, you know, there's a definite difference in the parties in terms of their ideologies and focus in terms of healthcare. And this is a very simplistic description, but it's worth just being aware of this as we go into the election, that in terms of how they view insurance, in terms of how the issues that they focus on, Republicans focus more on costs, the Democrats focus more on coverage, state versus federal control, the importance of entitlement programs, a very different view in terms of how insurance should be covered. The Republicans think there should be more personal responsibility, and so more high deductibles and use of health savings accounts versus more comprehensive coverage, responsibility and poor taxes, medical malpractice reform, physician and insurer focus, sort of support versus hospital, voluntary versus mandatory, and sort of who disrupts the system. And the thing I would just say is that, well, I'll explain this as I go forward, but this is a very sort of general overview that when you talk to a Republican, they're going to come at things more like this. You talk to a Democrat, they're going to come at things more like that. And then, really what happens, and people don't realize this, there's a lot that happens in Washington, a lot that gets done. Even though you think nothing gets done, a lot does get done, because you've got these two very different perspectives in terms of the base of their parties. But then they want to get things done, they want to compromise, and they will. And it's really finding that center point on these issues that is key in health policy. So I think it's really important to focus on what is bipartisan. And this list that I'm going to show you here is very important for people to be conscious of. So one very clear bipartisan thing is shifting public risk, meaning Medicare and Medicaid, to private entities who can manage to a budget. So in other words, Texas's Medicaid program is run by private Medicaid managed care organizations. That is an example of a program that used to be run by the government, now has been shifted and is run by private entities, private Medicare managed care organizations, Medicaid managed care organizations, who manage to a capitated budget. They are given a dollar amount and they are told, make it or break it. This is all you got. And that's where we're going overall. This is bipartisan. This is true with Medicare Advantage. That's something the Democrats also support. It's bipartisan. There's a difference in emphasis, but the Democrats, by and large, support Medicare Advantage as well as Medicaid managed care plans. Move from fee-for-service to value, let the private sector innovate and compete, get consumers information on quality, costs, and so forth. Have good measurement capabilities, increase access to data for both consumers and providers, and address sort of the social determinants of health, social influencers of health, overall. These are bipartisan areas of agreement. So the election. So this is my sort of overview points that I would make about this election. This is probably one of the most difficult times for an incumbent to run. When you look at the headlines, when you think about the history where incumbent presidents in the last century, if they're running within 2 years of a recession, only 1 out of 5 have won the election. If this election were run last January, when our economy was doing really well, and if you look at this chart here, in terms of the right track, wrong track of the country, most people thought we were on the right track back in January timeframe. In fact, it was almost a historic high. And then we've had it's gone down, obviously, because of the pandemic. And so this is really, this sort of right track, wrong track just underscores the point that it's very tough for the incumbent, President Trump, to get reelected in this environment. So these are just factors that are impacting the election. In terms of sort of what the pundits say, this is just one fairly recent assessment of where things stand on this in this election in terms of sort of the leanings of different states. In the Electoral College, you have to get 270 votes, and sort of where the critical votes, critical states will be. Florida is a huge battleground state, because whoever takes Florida is going to probably win the election, and of course the Democrats already start with an advantage because they've got the coasts, which have a lot of population, and they're just so heavily Democrat in terms of the voting majorities. So, and then there's a relatively small undecided population, but that is going to be the population that decides the election, as well as turnout. On the House and the Senate, this is the current breakdown, as I think most everybody knows. In terms of the House, the Democrats are in charge, and the Senate, the Republicans are in charge. And in terms of sort of where things stand right now, looking at the Senate races, which are the most important, because of course the Senate really is where things go to die. So if you can't get something through the Senate, it becomes critical to have the majority in the Senate. And of course, you all know you need 60 votes to get to pass cloture and so forth under the rules that exist now. So the Republicans have a tougher task because they're defending more seats. So they're more vulnerable, and you can sort of see the breakout right now in terms of the way the election, in terms of sort of what the prognosticators are saying. On the House side, I would just say that it's hard to see how the Democrats lose the House unless Trump does really well, and the Republican Party, he wins the election and pulls with him a lot of Republican seats in the House, and so he will make a big difference on the rest of the ticket. But when you look at the actual numbers, the Democrats have a decent majority, and then on top of that, there's 28 Republicans who are retiring, so those are open seats and therefore more vulnerable, versus only 9 Democrats. So in terms of the presidential race, this is just the realities of it. It's a tough environment for Trump, which may be why he performed like he did in the debate the other night. But he has to run on his record. The national crisis really increases public reliance on the federal government over this notion of draining the swamp. So that's a tough messaging that he's got from standpoint of where his identity is. I do think the way people are feeling about the country at the time of the actual vote, when people actually vote, is going to be critical. So October, this month, is going to be pivotal. So, if COVID, we get a surge and things are the economy's in bad shape and so forth, I think Trump's got a very, very tough uphill climb at that point. At the same time, the Democrats have not been united. They don't have the incumbency, which is this fear people have about changing horses in midstream. And so, there's also the other side where, could the Democrats actually succeed in overcoming Trump? So what I did here is I just took the major public policy issues that get debated in Washington. And I said, okay, so what does this mean? If the Republicans have control of the Congress and the presidency, or at least have a divided Congress, or if the Democrats, get a sweep, which my guess is that if they win the presidency, they could very well win the Senate, and which means they'll control Congress. But the way I simplify this is to say the Republicans are sort of more everything's focused around market competition, and the Democrats are much more around managed competition. And I think there's, without question, there's not a lot of difference when it comes to moving to two-sided risk. And what I mean by that is healthcare providers, and I'll describe this more in a minute, in a little bit here. Healthcare providers are accountable for the cost and the quality of care. So they will be pushed into a direction, probably more quickly because of the pandemic, towards being accountable for cost of care. Now, the Republicans do this more through Medicare Advantage, as well as two-sided risk models under Medicare. The Democrats will focus more on two-sided risk models under Medicare, so that's ACOs and bundled payment. And they will be less supportive of Medicare Advantage, but they certainly won't stop Medicare Advantage. It just won't. There's been a huge emphasis at building the Medicare Advantage program under the Republicans. Both parties aren't going to stop the movement to retail, ambulatory health, and consumerism. I think there's more conflict with payers under the Republicans than the Democrats, only because the Republicans give such an advantage to the Medicare Advantage plans and private insurers that the Democrats, will be much more provider focused. The pace of getting data out to consumers, as well as to providers, and getting rid of the silos of data in healthcare. So when I say silos, healthcare providers have silos of data, payers have silos of data, EHRs, electronic health records, they all have silos of data. This is all being broken down, and I'll describe this in a little bit. Regulatory relief, the Republicans are much more focused on that than the Democrats. State flexibility in Medicaid coverage, no surprise here. Much more flexibility to the states under the Republicans. Democrats will be much more federally focused and having, the feds support and actually press the states to expand Medicaid. Restructuring Medicare, not a lot of change under the Republicans, and potentially significant changes under the Democrats. But the buy-in to Medicare at age 60 is very possible under a Democrat sweep. ACA, you all know where that is. Prescription drug pricing. The Republicans try to use more market forces, but Trump has been very focused at sort of making our pricing more comparable to other countries. So they have reference pricing in a lot of the proposals that Trump is advancing. If the Democrats win, there's going to be a huge push to have government negotiation for drug prices, huge. And this will be a gigantic fight in 2021 if the Democrats win. Pricing transparency, both parties are pushing this, and both parties will continue to push this. And then 340B, this is a big issue that the Democrats are much more supportive of the 340B program versus the Republicans. So those are sort of the big issues. There's a lot going on in the courts, as you all know, including the Affordable Care Act. And then there's other healthcare policy issues like transparency and 340B reimbursement and public charge, Medicaid work requirements, site neutral payments. So these are all big issues that are being fought out in the courts right now. This administration will continue to implement these policies, face litigation, fight in the courts until they're told to stop. And frankly, they've been winning most of the cases thus far. So, this is just the reality that we have in healthcare, and it goes depending on, it doesn't matter who the administration is, there's going to be fights in the courts. And then, of course, we have this massive issue that's going to be debated in October around Ruth Bader Ginsburg's position, and Judge Garland, and of course the fight because he didn't get to be seated during the election. And the realities are this: Trump and McConnell are going to move forward. We all know that. They've got the votes. They're going to do everything in their power to move this forward. And the question is whether they get defections. And it'll be interesting to see whether Judge Barrett, Coney Barrett, if there's enough opposition that is brought to bear. She's a very impressive candidate, and it will be interesting to see if there's enough that can be mustered to tarnish her standing and reputation that Republicans will decide to vote against her. But right now, it looks like it would be hard to see that occurring. They've got the votes. I think it's going to happen, but this is going to be intense. It does have a huge impact on the ACA constitutionality, because 1 week after the election, they're going to hear the case in the courts. So before the Supreme Court, the question is whether Judge Barrett becomes a justice, and whether she's seated, or whether we've got a potential of 8 members of the Supreme Court. Right now, 4 members have already voted in support of the ACA. So right now, if there's a tie, it gets remanded back to the courts, the states, to the lower courts. And, I think it does create a lot of questions about what could occur. My view is the odds of it being struck down in its entirety are low. When I say low, less than 50%, probably more in the 40 or 30% range is my view. And that's because, again, 4 justices have already voted for this. The issue of severability of the individual mandate, which is the big question, becomes central. And, if the Democrats win the Congress, they could vote literally to eliminate the individual mandate from the ACA, and that would make the whole court, that would make the case irrelevant, because there'd no longer be an individual mandate in the ACA. So there's a lot that could occur. I think it's possible to sever the individual mandate, keep it separate, and let the rest of the law stand. And I think that's the most likely outcome. But that's kind of where we are. Let me just move forward here, because I'm a little concerned about time. Just see what time it is. Yeah, let me just go through these last slides, and if we have any time at the end, I'll answer questions. These are the 3 major trends I think people should be focusing on. So first is the movement to two-sided risk. So here is how our insurance system is largely set up, and it's really built around a Medicare model. And this is how Medicare was designed in 1965. It hasn't changed a whole lot, or it's until really the last decade. And it's basically got a bunch of silos, different payment systems, RVUs, APCs, DRGs, RICs, RUGs, and HHRGs, very complex and very payer driven. So the incentive in this system is get the patient in your silo, do services on the patient in your silo, and don't really think about anything else beyond your silo. So that's why there has always been this difficulty in healthcare around increased volume and around fragmented care and a lack of coordination and high cost, because the incentive is do more services. So policymakers have known this. They've been trying to address it for years. I describe the policy solution as track 1 and track 2. Track 1 is apply pay for performance on top of fee for service. So everybody is accountable for the cost and quality of the care that they deliver, in addition to the delivering the services. So there's a portion of your fee for service payment that is at risk based on your performance on 3 measures: hospital readmissions, efficiency, and complications. Everybody's moving in that direction, and all the measures align. So if everybody's thinking about readmissions and trying to keep readmissions down, it reduces cost. It also improves quality, because obviously you're not having people going back to the hospital. And that's what they're trying to incent, and it forces everybody to think outside of their silo. So if you think about track 1, it's basically micromanaging providers to think outside of their silos and to think in a way that's delivering outcomes that actually save money. That's an easy way to think of track 1. But track 2 is really what they're pushing to more aggressively. And we're really going in this direction overall. This is creating new models of care delivery that make providers accountable across the silos. So that's ACOs, bundle payment, patient-centered medical homes, things of that nature. If you go to one of these alternative payment models and you take accountability for caring for a patient, either entirely or in a bundle, like a 90-day bundle for hip or knee procedures or cardiovascular procedures, things of that nature. If you take accountability across the silos, you get a lot of flexibility from regulatory requirements, like the 3-day hospital stay, the ability to share savings, telehealth, post-discharge, home visits, a lot of things. Plus, you get a bonus payment as a clinician. So they're doing everything they can to make track 2 more attractive overall. That's where we're headed. On the rural health side, they have recently announced 2 new models under this program called CHART, Community Health Access and Rural Transformation Models. There's 2 major models. This is probably the future of payment for rural communities. It's based on upfront funding, provides a lot of regulatory relief. They also provide support to them, and you can participate either in this ACO transformation track, where you get upfront payment to be an ACO, and you're paid at the back end, and it's a capitated payment, or the community transformation track, which is described here, where you also can get a $5 million payment, up to $2 million for pre-implementation, $500,000 each performance period for 5 years. There's, you bring in Medicaid as well as Medicare, and it's a capitated program overall. So this is the kind of thing that I think is we're headed toward with the rural community. From the standpoint of hospitals, and the reality for hospitals is this, that there are a lot of pressures on Medicare payment that's making it difficult for Medicare. And from a payment standpoint, this includes cuts to 340B, site neutral payment. They're reducing, there's an overall reduction in Medicare payment and Medicaid payment. There's a shift from inpatient to other sites of care. So there's a variety of things being done by Medicare to shift payment away from hospitals. The private payers are doing the same thing. You've probably seen United Healthcare said that they're going to, any procedure that can be done in an ASC, a surgery center, will go there first, not to the hospital. There's a big focus on home health, outpatient, ambulatory, retail care. There's a lot of physician companies trying to organize themselves to disrupt hospitals. And these payment models that I've been talking about, these alternative payment models, the track 2 models, they all incentivize caring for patients in less expensive settings of care. So from a hospital vantage point, if you don't continually disrupt yourself and innovate the care delivery process, you're going to be in trouble. Second major trend is towards consumerism, and a lot of this is being driven by the liberation of data. And this is a very important policy area that's under significant change is going on in this regard. So the policies that are going on are going to require that claims data be made available to consumers, so that your phone, you're going to be able to get apps that show you where you've gone to get care using claims data, the cost of care at different locations. You're going to have data apps that are going to make it much more easy to shop and understand what your personal situation is in terms of your personal risks, your comorbidities, your drugs, things of that nature, as well as the providers you could potentially go to. They're going to make this claims data available for all the Medicare and Medicare Advantage, Medicare fee-for-service, Medicaid, and exchange plans. And then the private plans will be copying this as well. So that's a major change. You're also seeing, EHRs have to open up their data, and providers have to make that data available to consumers. So you've got all these data liberation kinds of things, and the development of what's called a data blocking rule. So you can't block the release of this data, either if you're an EHR, if you're a payer, or if you're a provider. It's going to mean data will be able to be moved around the country. There's going to be a lot more transparency of price and quality information. And of course, hospitals have to make 300 shoppable services, publicly available on the 1st of January of 2021. So from consumers' vantage point, more empowered, more different kinds of measures that are going to be available, like your doc rating systems and so forth, medical records at all sites of care. You got to market in a very different way. You're going to have these apps that I mentioned, like Waze for healthcare. So some of us may use Waze to navigate ourselves. We're going to have the same thing in healthcare. Demand for transparency and pricing data, and people will be carrying their data around. For providers, so that's what it means for consumers. For providers, it means you're going to be able to have much more applications through your EHRs to support physicians' work with their patients, as well as their ability to get patients to interact with them electronically. You're going to have to manage the consumers. You have to manage the fact that you're going to be judged on doctor compare, so to speak. You're going to have to understand that all these patients coming in with all this information that they're going to be bringing, even more so than they have heretofore, marketing and so forth, claims data, and it's going to help providers manage the total cost of care, because they're going to be able to get claims data. It does mean liability exposure, clinical apps, and you've got to be pricing competitive. And of course, we see all of these new retail outlets starting to show up as well, because these retail providers are saying, we need to reduce the cost of care. There's a population that would like to be able to use all these apps in these less expensive settings and get care at less expense, and we're going to be delivering it. So it's going to be very disruptive to the system overall. The last major trend that I like to stress is payviders. And when I talked earlier about shifting public risk to private entities, this really leads to payviders overall. So think of it this way. The average Medicare beneficiary costs $13,000 in the country. The average Medicaid beneficiary costs $5,000. The question is who's accountable for that budget, okay? It could be a provider through an ACO or a bundle payment system, or some of the other models like primary care first, or it could be an insurer. Who's got a Medicare Advantage plan, a Medicaid managed care organization, or the exchanges. If you're a provider and you take risk, you got to change the care delivery process. You got to use data to understand your total cost of care. You've got to use multiple sites of care to get access. You've got to coordinate with them. You've got to integrate the care delivery process, organize your community, partner or become an insurer, eliminate variation and inefficiency in the system, and partner with downstream providers. There are things that you need to do. If you're an insurer, well, the insurers do what a lot of folks probably recognize, which is no pay, slow pay, prior authorization, things like that. But then increasingly, you're seeing payers becoming providers, like United Healthcare, which employs 50,000 clinicians. They're an example of a payer that's becoming a provider. So this is why I say payviders. So these are the things that the insurers do. And of course, they're going to shift risk to the extent they can to providers. So this is what is going on in healthcare today. This is how it's playing out with payers in terms of how they're partnering with different players in the system and becoming providers themselves. Like you look at the non-acute physician, pre and post-acute care providers that these payers are doing. And if you look at United Healthcare, they've got a lot going on there that they now own. So this is where we're going from and to larger regional markets, highly reliable and more standardized care across the continuum, narrower networks, total cost, thinking about total cost of care, much more patient-centric, measured and transparent, use of data and analytics, more personalized medicine, technology enabled in a variety of ways, more focus on episodes of care rather than single serve in those silos that I talked about earlier. Star physicians to star teams, active employer contracting overall by health systems. So that's where things are headed. Those are the major trends. And I've probably lost everybody and in this presentation, and I'm hoping that's doesn't leave me any time. Do we have any questions, or am I out of time and we just need to stop?
Thank you so much. We have time for a couple of like to bring those forth. Just unmute your microphone and start asking.
Okay. We'll see if we got any questions. Let me tell you, I just told you a lot of stuff. If I'm hoping it makes sense.
There has been a couple questions in the chat session.
Okay.
One of them says, do you expect the polling in the presidential race seems locked? Do you expect the race to tighten in October? And speculate a little on what happens regarding the Texas case challenging ACA. And you've already talked a little bit about that.
Yeah, I've talked about that one. I still think that the ACA will not get struck down. I said what I thought the odds were. But there's a lot of variables. It's interesting. Judge Barrett spoke against the decision that was made in 2012 when the constitutionality of the ACA was litigated. But I think there's a big difference between that case, which was around, really did rest on the individual mandate versus the issue of severing the individual mandate, which is, what could be done to solve this. So I will see. There's so many variables. The election will have a huge bearing on what occurs here, because again, if the Democrats win, they could easily stop this case by just passing a law that says the ACA doesn't have an individual mandate, period, and just take it out of they could sever it legislatively, which ends it effectively in the courts. So there's things that can be done legislatively. Depending on what happens in the election. I also just don't think the court will actually strike it down in its entirety. They will find a way to sever the individual mandate and keep it separate, and that may no longer stand, but the rest of the law would stand. So that's the ACA. In terms of, what was the other question?
The other question, would you expect the race to tighten in October?
Oh yeah, well, the Titans. I really think it's got a lot to do with what happens in the country in terms of, as I said, the economy and the pandemic and coronavirus. I think what's scary is that we're looking at these layoffs occurring by Disney, the airlines, and others. And, they're not going to probably be able to, if they don't get an agreement, and it's probably more in the Democrats' interest to not get an agreement. So they're just driving everything really hard from a negotiating vantage point. I would say that Pelosi's probably got a stronger hand, and if they don't get something done, it's going to increase public dissatisfaction, which is going to hurt Trump's reelection situation. So while I think Trump is a very, very effective campaigner and gets out his base vote very well, it's the independents that are going to decide the election. And I do think the Democrats are as motivated as the Republicans. So, if people are feeling bad about the way the economy is going and if we get another surge in the pandemic, I think it's going to be very, very tough for Trump to win.
And we have someone asking for access to the presentation that you provided? It was a really good and informative presentation. It went by so quickly. Is it possible that the presentation could be?
Yeah. I'll send you I'll send it to you, and you guys can have it. I just literally gave everybody, about as comprehensive a perspective about what's going on in healthcare in 45 minutes that is humanly possible. So if you're not getting it all, I'm not surprised because there's a lot there.
Yeah, it was very comprehensive. There was a lot to think about there. Does anybody else have any questions for Blair Childs?
All right. Well, it's been great. I hope it was helpful. I hope the fact that there's no questions doesn't mean that everybody's falling asleep, but you never can tell. So
thank you very much, sir. We really appreciate what you presented.
Sure. Sounds good.
It was very, very informative.
You bet. Thanks so much. I'll talk to you all later.
Okay. Thank you, sir.
Yep. Bye.
And now, what should we do? Okay, what? Okay, should we go ahead? Okay. Okay, we're trying to figure out what we're going to do. Okay, if Dr. Grace Lee is ready, we'd like to go ahead now. And so, is she all ready? Okay, she's on. All right, very good. Let me introduce Dr. Grace Lee then. She is an assistant professor of Translational Sciences with UT Austin College of Pharmacy and adjunct professor at UT Health San Antonio School of Medicine. She received her Doctor of Pharmacy degree from the University of the Pacific, the Thomas J. Long School of Pharmacy, and her Ph.D. from the University of Texas at Austin. She was with Kaiser Permanente as an infectious disease pharmacist and clinical coordinator. Her main areas of focus are in infectious diseases and aging, and she currently leads clinical trials in immune health, aging, and vaccines. So, Dr. Lee, it's all yours. Thank you for being here.
Oh, there you go. Can you hear me now? Can you see my screen?
Yes, we can. You're all on.
Okay, perfect. Well, thank you so much for that introduction, and good afternoon, everybody. And I'd like to thank Paula Winkler from the South Texas AHAC and Kelly Cheek for inviting me to speak today. I'll be kind of going over a different perspective today, more of a public health issue on the importance of flu vaccinations, particularly this year in the landscape of COVID-19. And what we'll do is we'll go over and discuss the impact of COVID-19 and what it's unveiled thus far and the current status of that. And with that, discuss why, and particularly this year, the influenza vaccination is extremely important and a high priority this year. And then we'll go over specific recommendations from the CDC. So even though we're about 8 months into the pandemic now, we still haven't really rounded the corner of COVID-19. And although there's been positive signs in certain regions, certainly, particularly in Arizona and the Northeast, there's some areas still with very intense activity. And so Texas is considered still in the red zone, indicating there's more than 101 cases per 100,000 in the population. In particular, more than 10% of US cases are reported from Texas. As of yesterday, it was about 743,000 cases with confirmed cases with claiming the lives of about 15,711 deaths. With that, what's important is that our hospitalization rates have trended downwards, which is great, and it's under 5,000, but it's remained stubborn at about 4,000, at the 4,000 range, and hasn't really budged much below that. And of course, certain activities have increased with the activities with colleges opening and schools opening and other businesses opening as well. Now, while all currently reporting counties reporting positive activities, there's certainly some counties that have been affected disproportionately than others have. And here, evaluating the fatalities by counties, you would expect to see that the larger metropolitan urban regional areas have been very hard hit. But then you also have these other counties, including rural counties, and those with higher proportion of underrepresented populations that have been particularly hard struck. And so some examples include those bordering countries, including Maverick County with Eagle Pass. And here you have Hidalgo County now reporting the second highest number of deaths in the state, right behind Harris, and as well as Starr County, a rural county there, reporting about 53 cases per 1,000 population, which is double the state average, with a case fatality rate of about 5%. And so Starr County, I just use as an example here, a rural county, and much like other rural areas, was facing the perfect storm of challenges when it comes to containing the virus, including limited capacity for testing and contact tracing, essential providers falling ill or requiring isolation themselves after being exposed, which further reduced the healthcare capacity in this county, which only has one hospital, a 48-bed hospital with no intensive care unit to serve about 50,000 people in the region. And so back in July, they had reached capacity and really had to face just really extraordinarily difficult situations in allocating resources and triaging care. And at that point also had begun transporting patients, critical patients, intubated on ventilators, on helicopters to other urban areas and other urban hospitals. And so during this time, critically ill patients from several different regions like Starr County and Eagle Pass were helicoptered to other larger hospitals. And this was very, very difficult on many different levels. But one being that, these patients are now hundreds of miles away from their home and family. But here's an example here that I wanted to show of a couple that the South Texas VA brought in July as humanitarian transfers. It was really special that they got to be with each other. And I just highlight these sort of examples as to why it's important for the flu vaccines and really keeping these beds open for the patients who really need them in our currently overstretched healthcare systems, particularly in rural areas. We've also learned several different risk factors with COVID-19, and this is really important because many of the risk factors in vulnerable populations for COVID-19 are very similar to what we see with flu. So those include those that are 65 years and older, and in the context of COVID, while only accounting for 15% of cases, those who are 65 years and older accounted for 80% of total deaths in the US. But it's also important to realize that really it impacts all populations when you look at the hospitalization rates by age group on the left graph. And important to highlight that 1 in 5 people hospitalized for COVID were between the ages of 20 to 44 years of age. And majority of the adults, about 90% of adult patients had some sort of underlying medical condition similar to risks for flu. And there's also increasing and substantial amount of evidence that there's racial and ethnic minority groups that are being disproportionately affected by COVID-19. And so here, this is data from the CDC where they show that COVID-19 is associated with hospitalization rates that are much higher in people who are non-Hispanic, American Indians or Alaskan Natives, African Americans, Blacks, and Hispanic or Latino compared to non-Hispanic whites. And the risk of death among Blacks in particular about 2-fold higher than those compared to non-Hispanic whites. And so certainly many of these disparities are also associated with some complexities that are associated with the populations themselves with a higher incidence and prevalence of comorbidities and health access that make it more likely for them to have poor outcomes. So really, summarizing this for why I state sort of where we are with COVID here is that the flu season is coming. And currently the state that we're seeing now is that COVID-19 cases are declining or remaining stable. But there are still some regions, including some areas in Texas, where they're experiencing intense activity. And we've seen how easily a small outbreak can then turn into a larger epidemic. And there's certainly several high populations who carry particularly higher risk for COVID infection and worse outcomes, including healthcare workers and staff at long-term care facilities, Blacks and Hispanics, vulnerable regions such as rural areas with less access to routine care, and adults with underlying comorbidities. And with the current landscape as of today, is met with the challenge that there's really limited therapies against SARS-CoV-2. Certainly there's been a lot of progress in this area, but as of what's currently available is really for severe cases of COVID requiring IV therapy or hospitalization, and not much for earlier disease or something in the ambulatory care setting. While there's several potential vaccine candidates in development, several in phase 3 clinical trials right now, they are not currently available. So again, I highlight all these again to highlight again that this is important because now the flu season, we're actually in the flu season. and with that landscape of COVID could really certainly make for a potentially catastrophic situation. In that COVID-19 and influenza together could then potentially be competing for the same hospital bed, oxygen, ventilators, the same staff. And so hospitals in the US and in Texas who are already stressed and overstretched and trying to still recover from the surges that they've experienced now must brace for a new wave of patients with flu. And we know that each year influenza poses a substantial burden on communities and healthcare systems. In the last, over the last 3 most recent flu seasons, influenza is estimated to have been associated with 29 to 56 million illnesses, 14 to 26 million, or 18 to 26 million medical visits, 410,000 to 740,000 hospitalizations related to flu, and up to 62,000 deaths in the US. So, even in a relatively mild or moderately severe flu season, in the presence of co-circulating SARS-CoV-2 could significantly amplify the cases of acute respiratory illnesses. And we know also that being infected with influenza could certainly compromise the immune system to then potentially be more susceptible to COVID-19 and to fight off COVID-19. And this is complicated in particular and provides and presents a major challenge to providers and clinicians in that and for both illnesses, early diagnosis is really important and an essential point for essential point of care. So in terms of COVID and flu symptoms, unfortunately, is that they look very, very much alike. They both can cause respiratory illnesses with very similar symptoms, but are caused by very different viruses. And so many of the symptoms overlapped. One distinction, though, however, that we learned with COVID is that patients with COVID often complain of loss of taste and or smell, but this alone is really not enough. And unfortunately, there's really no clinical or specific clinical manifestation that could distinguish early COVID versus influenza. And so right now, the only way to distinguish between the two is with a diagnostic testing. And currently that's through a nasopharyngeal swab for PCR. And so one of the most important actions we can take towards eliminating really this extenuating challenge upon providers is really to get the flu vaccine and is to do the best we can to get flu off the table. And so we know that getting the influenza vaccine, and especially this season, is the most important thing we can do to protect not only ourselves, but really importantly, the people around us and our community, as well as reducing the stresses on our healthcare system. And just to look back and to think really just in July and the degree that we saw how stretched Texas was in the degree of morbidity and mortality and the overload on our healthcare systems, and as well as in other regions like New York, we really want to avoid seeing that again as much as possible. And so again, critical is vaccination this year. For this year, the recommendations on who gets the vaccine has really not changed, in that it's recommended for all persons 6 months and older, and or who don't have a contraindication. But particularly during the COVID-19 pandemic, we have to do a much better job to critically reduce the number of cases in flu in protecting vulnerable populations at risk for COVID and or severe flu. And that includes a focus on essential workers, like healthcare personnel, including those working not only in the hospitals, but in the nursing homes, long-term care facilities, where we know really was a very vulnerable place this year, comprising majority of the deaths in the elderly population. Also, persons at increased risk for severe illnesses of COVID-19, and they overlap a lot with those that are at higher risk for flu complications. And those, again, include those that are older, who are older, 65 years and older, residents in a nursing home or long-term care facility, persons of all ages, really, with underlying medical conditions, as well as those, again, persons at high risk for influenza complications. And those are listed here. And again, many of the high priorities for flu vaccinations, or priority groups for flu vaccinations, also include those for COVID-19, including older age and immunocompromised people, and those with comorbidities, including heart, lung, kidney, and liver diseases. One of the main differences here that I've bulleted there in red is that influenza has a profound impact in young children. So particularly less than 2 years old is associated with worse disease or severe disease and hospitalization and death. But the one saving grace in this pandemic is that COVID doesn't seem to have such a profound impact on our youngest, less than 5 years old. Flu seasons in general can be quite unpredictable, and much of it has to do with how well the circulating strains match those that are contained in the vaccines themselves. And some years they're better matched than others. We still don't know how this year's gonna pan out. But this year's vaccine has been updated to better match the viruses expected to be going around the United States this year. And vaccines usually comprise of 3 or 4 viruses, depending on the vaccine, comprising of 2 type A influenza viruses and 1 or 2, depending on the vaccine, type B. And so there's several different formulations that are available, and just 2 new types that I wanted to highlight there for those who are older adults, providing a higher dosing, as well as an adjuvanted vaccine formulations. And there are other cell-based and recombinant vaccines that are available for those with egg allergies. Now, this question always comes up, and really how well do these flu vaccines work, and how well do they actually prevent the burden of disease? And so there's certainly several factors that determine how good a vaccine is and how good it will work in a given year. And that includes individual characteristics, including of the person getting vaccinated, including their age, just general health and immune status. You have viral characteristics, including the strain virus and how virulent it is, the dominant strain is, and how different it is from previous years, and getting a general sense of the circulating immunity in the population. And influenza vaccine effectiveness, meaning how well does it prevent disease, and this can be impacted by vaccine uptake, so the proportion of the population that actually goes and gets the vaccine, as well as the match on how well the flu viruses in the community and circulation really match what's in the flu vaccine. And so flu vaccination effectiveness has been variable, ranging anywhere from about 20 to 60%. Which has sometimes disappointed, people to say that they find it not effective. But while we all want the numbers to be higher, what we do know is that importantly even when the effectiveness of vaccine is low, with higher uptake can have really major impacts in reducing the overall burden when more people are getting the vaccine. So here, for an example, the vaccine effectiveness in the 2018-19 season was about 29%. That's relatively low. But even at that low effectiveness, with about 49% vaccine uptake, that's about 50% of our population, that the CDC estimates that this averted or prevented 4.4 million illnesses, which over here on the figure is equivalent to more than the population of Los Angeles alone, as well as 58,000 hospitalizations and 3,500 deaths. So this can have a major impact even when effectiveness is low, especially when more people are getting vaccines. But we need to be more proactive and how to get more people to get it. And we'd like to see numbers higher than 50% of the population. So in terms of what to expect this season, I mean, what we're expecting as in the US and Texas is that SARS-CoV-2 will continue to circulate and will co-circulate with influenza, potential co-infections. And that there may be co-infections of SARS-CoV-2 and influenza, which we don't have much data on really the outcomes and what this looks like in the manifestations, but intuitively can hypothesize that the likelihood is high that people with both infections can currently be associated with worse outcomes. And so this is really a particularly complex setting for clinicians and really need to depend highly on rapid diagnostic testing to distinguish between the two. And really that's essential because distinguishing between the two have two very different implications in terms of infection control measures as well as treatment options, where for instance, for influenza, we often treat it empirically, and there are oral drugs that are available. On the other hand, we know for COVID-19, one of the therapies that have just recently shown support in improving clinical outcomes is the steroids, which is something that we want to avoid in patients with influenza. But on a positive note, however, that there are interesting reports from the Southern Hemisphere, which has often sort of forecasted what will happen in the Northern Hemisphere flu season, is that they've seen a much lower incidence of flu activity this season. There's less testing of viruses and detection of viruses in general. But here, for example, this is a case out of Argentina of their rates of influenza this past year, and you can see in black the year 2020 is vastly lower relative to prior seasons there in orange. And what's also important to note there is that they note that in March, which is right before their earlier peak in their flu season, is when they began the mandatory measures of lockdown in terms of masking and social distancing and things. And so it would be, when we're looking into this season in the Northern Hemisphere, where we don't have a vaccine for COVID yet, we know that an important way to decrease the overall burden of respiratory diseases, it may be is via vaccine, but may also be continuing these preventative interventions like masking, hand hygiene, avoiding crowds, and social distancing. That decrease COVID, but also can reduce the spread of influenza. as we've seen in several of these countries in the Southern Hemisphere. But we also saw this as a trend in dropping off of flu activity towards the end of last year when COVID-19 began. And of course, one of the most important ways and powerful way of decreasing the potential dual respiratory epidemic is by providing the flu vaccine. And just a degree, again, of what we saw in Texas and the overload in the healthcare system, I'd say I would say anything we can do to decrease the community viral reservoir should be a high priority this year. And when it comes to the flu vaccine, it really is one of our most powerful tools, and particularly important to protect our higher risk, more vulnerable groups. And one of the most important points as well is that we could have these vaccines available, but we need people to actually take the vaccines. So more attention than any other prior years is being paid this year to persuading more Americans to get the flu shot, which in the past has been about 50% or less, and even lower, about 20% in rural communities or those lower socioeconomic areas and those with higher underrepresented populations. And certainly there is specific unique perceived barriers this year in the landscape of COVID, because many of the venues, traditional venues where vaccines were normally delivered are not available the same way this year. So for example, school closures, or at the workplace, where 15% of the adult populations usually get vaccinated, where people are working at home and are less available. Also COVID-19, due to COVID-19 precautions, there are less in-person clinic visits, which have been canceled or moved to telehealth. In addition, there may be just more concerns and misconceptions regarding COVID-19 in and of itself or the COVID-19 vaccine, and includes people just not feeling safe to going into clinics and pharmacy settings to receive the vaccines. In particular, I've been hearing some older adults and those who are immunocompromised concerned about going to get a flu vaccine because they are higher risk. But those are the exact populations that need it. And so certainly we have to do a better job of the messaging and ensuring that it is safe. It does look a little different this year than in the past, that you're going in with a mask and you're having to stand 6 feet apart, but the planning and getting is the same, and the importance is more than ever. And so overall, we as public health and medical providers need to really have a united front and similar messaging and concerted messaging about the benefits of the flu vaccine, particularly this year. And in one ways, some of the ways that people have been most successful in discussing vaccine hesitancy, for instance, is really to share stories. And so our biggest successes have always come from not really sharing data, but from stories. So including people who have suffered from vaccine preventable diseases in the past, and sharing those have demonstrated to be more important. So they resonate with people more personally. And so the CDC and Medscape together collaborated to provide a very informative, really short messages of series of clinicians on what they did and how they recommended a flu vaccine for a particular patient that given year. So other additional activities for successful vaccination, again, is to have the same critical messaging across, And really at this point is to capture everyone when we can and vaccinate when possible. It's important for all providers really to be on board and being active and proactive in assessing vaccination status and administering routine vaccinations, which we know have dropped about 50% among children this year because during the COVID pandemic. And so when they're coming in for their visits, it's particularly important to catch them when they can and to ensure timely vaccination catch-ups. It's really important to engage the community and community outreach to understand the needs and share education and really debunk some misinformation or misunderstandings and vaccine hesitancy. Of course, active communication is important with active vaccine clinics and campaigns. And importantly, increasing vaccine availability and allocation. This year, more than 190 million doses have been available, which has been more than ever in historic years. And almost every single pharmacy and doctor's office should have some flu vaccine in stock. With that, we do need to take particular precaution this year in offering a very safe environment, including social distancing and requirement of masks. But in particularly this year, we have to think about different creative or innovative approaches in providing the vaccine and making it accessible, particularly to vulnerable populations, as well as certain regions where perhaps a pharmacy is not available or with lower access to healthcare. And so some examples include from the CDC website include mobile units and satellite units where they have very detailed guidances on how to for the infrastructure and the planning for those units. As well as drive-through clinics, which is what we've instituted here at the San Antonio VA, where we have campaigned to specific populations, and particularly those who have convalesced from COVID-19, to come through a drive-through clinic 1 year, and it takes less than 5 minutes. They don't have to get out of their car. It's really simple, and the veterans have really appreciated that. Accessibility. Importantly, pharmacists and community pharmacies can play a very important role in expanding access and providing in a very convenient way. We know that that about 9 out of 10 Americans live within a 5-mile radius to a pharmacy. And pharmacies are usually open with extended hours of service. They remained open during the COVID-19 pandemic, and they can come in without an appointment. And so that certainly opens up a lot of access. In addition, pharmacists have access to patient medication histories and medical histories and profiles in their management systems, and they also get to know their community members well with monthly pickups of prescriptions. So pharmacists could play an important role in educating and providing immunizations, but also as identifying those higher risk individuals who haven't yet received their vaccination. As of last year, about a quarter of all flu vaccines were provided at a community pharmacy. What we're excited about was that recently, as of August 19th, 2020, pharmacists can now provide adult and pediatric vaccinations. So prior to this, pharmacists were privileged to provide adult vaccinations. So now we could provide adult and pediatric vaccinations to increase access and improve vaccination rate for the whole family. In terms of offering where and access for flu vaccines or any vaccine, the CDC maintains this website called the Vaccine Finder, which is a really easy way for people to identify and find providers or clinics that are offering seasonal flu vaccines or other vaccines. I quickly put in a zip code yesterday, and it listed 66 different providers within a 10-mile radius. So it's a pretty comprehensive site and very simple to use. And so overall, and in closing, I just wanted to highlight again that the flu vaccine is really one of our most powerful tools that we have in stopping the possible twindemic. And the upcoming flu season could really potentially derail progress made in bringing down the COVID-19 rates. And if we don't take control in continuing our infection prevention measures, as well as improving our vaccination rates, this twindemic could certainly and easily overload our healthcare systems, even in our most advanced hospitals. And so we certainly need to take action now as providers, clinicians, pharmacists, healthcare administrators, community members, a parent, grandparent, in minimizing the impact of flu this year. And really one of the strongest messaging is that it's important to get the flu vaccine for yourself. But that decision of getting the flu vaccine really may save another life, or may make available a hospital bed for somebody else that really needs it for COVID-19. And I'll stop there and want to thank you for your time. I know I went through fast to make sure I got done in time. And again, I wanted to thank Paula Winkler for giving me the opportunity for me to speak to y'all today. I'd be happy to take any questions if you have some.
Thank you very much, Dr. Lee. We really appreciate all of your information. Let me just kick off the question. How do you think this flu season is going to go based on...
I'm sorry, I cannot hear who's talking.
Can you hear me now, Dr. Lee? Dr. Lee, can you hear me?
I can.
Okay.
Faint.
Yes, thank you so much for the presentation. I'm just curious, how do you think this flu season is going to go? Do you think, based on what took place in the Southern Hemisphere, it's going to be a below normal flu season, or do you think it's going to be like this?
I'm sorry, it became faint after a while, but I think that the question was in terms of what the flu season would look like.
Yes, yes.
Yes.
Yeah.
And certainly we don't know, but there's been hope in speculating that if consistent with prior years, in that the Northern Hemisphere sort of parallels that with what's seen in the Southern Hemisphere, is that we're hoping for a much less magnitude of a flu season. But that's contingent on several measures. Again, one may be because we are seeing the unintended benefits and impact of other infection prevention measures that we've taken for COVID-19, including masking and physical distancing and such. And that's certainly what we saw in the trend of the Southern Hemisphere, was that shortly after they instituted that, they've seen a drop-off of influenza. And in many of those countries, including Australia, that's seen that, also have had a higher uptake in vaccine coverage. So certainly there's two main strategies in hopefully seeing a much lower degree of influenza. I mean, with an influenza season last year associated with about 60,000 deaths, I mean, we can get down to, 10,000, or I mean, even lower than that, would be a substantial leap in in our improvement of outcomes and reducing burden of respiratory illnesses this year. And as much as we can do to prevent just taking flu off the table when we're still in a COVID-19 pandemic, I think would be is essential and critical this year.
Okay, thank you.
I think somebody's talking, but they dropped off.
Hi, hi, Dr. Lee. This is Paula Winkler. I'm just wondering, we're getting so many, within the clinical trials area, we're getting so many different types of messages. And I heard you talking about messaging as being a big factor in talking to people about flu shots. But we're getting a lot of messages regarding when the clinical trials will go through, what we do with them. Do we want to be the first ones to be able to run this through? I mean, what is the usual process for these types of clinical trials? I know we've fast-tracked it much more so because of the current issue, but what is usually typical within clinical trials and a vaccine, whether it be flu or whether it be corona or virus or whatever? What is the usual process?
Sure. With usual clinical trials, especially with vaccines, there's multiple phases. One is to first establish efficacy and safety, and that it mounts, and particularly with vaccines, that an appropriate immune response, and that it's safe. And that's usually conducted over a series of several years. And so certainly this year has been very unusual and actually exciting in that we were able to fast track now within a matter of 6 months, 4 candidate vaccines. Now other countries, like Russia have already approved the vaccine. So I think that, we have really accelerated our minds in how concerted efforts can really improve the availability of vaccinations that is vital to containing a pandemic. I think with the messaging this year, and the confusion that lies is sort of, when these vaccines will be approved. But I think we have to, as from the public health and sectors and the medical community, have to be on the same front that these vaccines, as well as the FDA and governing bodies, that these vaccines will not be approved until they're proven safe and efficacious. And so certainly the current COVID vaccines will too have shown really great immunogenicity. But one thing that we know we can't really see in phase 3 clinical trials necessarily is really the long-term safety effects of these vaccines. And to govern that, there's usually a DSMB, an external DSMB board that really regulates these decisions in both evaluating safety and effectiveness, efficacy and effectiveness in a clinical trial. And so, with these different factors and of course different complicated layers, particularly this for the COVID-19 with the political realm and background, it's been very confusing for the public. And we've seen surveys that have come out on who's willing to take a COVID-19 vaccine, where several months ago, I think it was about 55%. And I saw recent surveys of last week, it just dropped down to about 40%. And majority, 90% of those are would not want to pay money for them, or if they had to pay, would pay less than $20 on average. So, and one of the main fears is really just in and of itself, the misconceptions of vaccinations themselves, so vaccine hesitancy. And then of course, another concern is sort of the mixed messages that have been shared from different leaders and versus those of the healthcare community. And so certainly I think for us, we need to stay, or at least, for the medical community is to stay where the data is, and let the science speak for itself, and to be completely transparent as much as possible, and engaging communities and advocating, especially for those in rural areas or less representative minorities and certain populations that we know who are hard hit. And we have to make sure that they are well represented in these clinical trials, because vaccines or other therapies may work differently in different populations. So we certainly want to make sure that these populations, especially the vulnerable and higher risk, are well represented. So that was a long answer to your question, Paula, but I hope that addressed parts of it.
Well, Dr. Lee, thank you very, very much. We really appreciate your participation in this webinar. We really think the information was really useful, so thank you.
Thank you so much.
All right. And that concludes then this webinar. We really appreciate everybody listening in. And on behalf of the Texas Rural Health Association and Kelly Cheek, thank you very, very much, and have a good afternoon.